plug for Mayo. Dr. Hickson, chair of nephrology years, worked on stem cells, so she's published in stem cells in folks with diabetes. She now has an open study for any kind of kidney disease. I don't remember the specific criteria. It may be a narrow group of people, but consider enrolling in the study. It could help you, but it would certainly help people in the future at looking at alternative ways to protect the kidney, maybe even kind of rejuvenate them where they work longer. So we're trying to avoid this. We talked about peritoneal dialysis. This is hemodialysis, and that's our goal. And you have the option of getting transplanted early before you need dialysis. But the reason why the dialysis wants to be avoided is because it affects your life. So I'm 65, I just threw this up here. I have 15 more years according to the census in 2003. The numbers now are slightly worse because of the COVID, dropped our lifespan. But if I'm on dialysis, I got 3.8 years, all right? So dialysis is life-saving, you die without it, but it never promises you the life you would have had if you didn't develop kidney disease. Just as a plug for what I do, transplant would give me 9.6 years, somewhere between 2 and 3 times longer life. And that brings me then to our next topic, and that is kidney transplant. So these are the twins that had the first kidney transplant that was successful in the US in 1954 in Boston. Dr. Murray is a surgeon in the bottom right, won the Nobel Prize for this work. Really, truly amazing story. And it made transplant very popular, and it's even more popular now. So it's probably, in my mind, the treatment of choice for chronic kidney disease, stage 5 or end-stage kidney disease. If we have pig kidneys everywhere, we have an implantable dialysis machine, both of which are on the horizon, maybe they will supplant this. But currently, it beats dialysis. Preemptive transplant, the way to go, and there's a legislation to try to promote that, so Congress actually got something right a couple of years ago in promoting this so that we get more people getting transplanted early. It's not a cure, you gotta take anti-rejection medicines to make this work. They do have some nasty potential side effects, but even with those, I already showed you, you live longer, and every study has shown better quality of life with transplant than with dialysis. So who do we transplant? Here, anyone from 18 to 80. I'm a big advocate for the old people because I'm old myself, all right? So they keep beating on, no, we're not going to transplant, but we transplanted an 83-year-old about 2.5, 3 months ago, and she's doing well. You can't be transplanted unless your GFR is 20 or less. Most people need dialysis between 10 and 15. So again, preemptive transplant the way to go because it improves your health. You generally can't have active cancer, and if the cancer was recent, it's got to be in remission a long time for some cancers. Skin cancer like basal cell, no problem. Melanoma, that's a problem. So we would have to risk stratify you if you come with cancer history. We do transplant people with HIV, they do just as well as anybody else. We do now transplant hepatitis C because we can cure it. You can't have significant active heart disease or peripheral artery disease. You can't have untreated psychiatric disease, but if you're depressed on Lexapro, half of the country is, so we're okay with that as long as it's controlled, all right? And of course, you gotta be able to follow doctor's orders. So the workup is really simple. It's a lot of education, written videos, you have in-person classes, and then you get to meet this team, as we talked about, who are evaluating you and fixing problems or adjusting things to improve your chances of success. There are a battery of blood tests and scans that you have to have, and when it's done, you get presented to the selection committee. So this is not the Spanish Inquisition, it's just a bunch of people that get together once a week. They look at the workup and they decide yes or no. They get communication to the patient and their doctor. If you get listed and there's no living donor, you got a 36 to 72 month wait here at Mayo, depending upon your blood type. It's not unusual, for example, in California, New York, to have 5, 10, 12-year wait. So be aware of that. That's where getting the message about donation, particularly living donation, would be very, very helpful. So I'm going to end. I'm glad we did the stand-up, and hopefully not too far over. Love your kidneys. And to do that, know your GFR. If it's low, see your nephrologist. And then none of the things that you can do, but your doctor can remind you. It's a lot of information covered in a very short period of time. But there are some new developments that are going to markedly improve the ability to diagnose and then to help maintain function. And if the kidney fails, there'll be new options here with some of the other just fascinating kind of research, such as pig organs and even the implantable dialysis machine. So look forward to that. So I do want to recognize the stories. They've touched my heart. It's a lady that I just got a picture of when we were back in the old hospital over at St. Luke's. It's now St. Vincent's Southside, I think. And I did get third rating. I was below God, Dr. Wynn, but at least I made the board, so I was very happy. But in reality, she's saying delivered, me, so she's very happy. But ultimately, she's the one that does all the work. We give her a little assistance. And that's also key then in making your own decision. Do you have kidney disease? And if you do, the more you participate in your own care, the better the outcome is. And we can all hope for success like this young lady had. Thank you very much.